All right, good morning, everyone. Today is 26 September 2024, and this is the hearing for the House Select Committee on Homeland Security. Mr. Secretary, please call the roll.
Thank you, Mr. Chairman. Chair Gallet.
Here.
Here. Representative Amade. Here. Representative Carlson. Here. Here. Representative Cruz. Here. Here. Representative Desautels. Representative Edmiston. Representative Egan. Here. Representative Fisher. Representative Guyman. Here. Representative Kerner. Here. Representative Knox. Here. Representative McCormick. Here. Vice Chair Owen. Here. Representative Reiser. Here. Representative Selders. Representative Tarver. Here. Representative Wiley. Representative Wiley. Here. We have 13 members and a quorum.
Thank you for that, Mr. Secretary. Some housekeeping. Please silence all your cell phones. If you need to take a call, please step outside. If you are planning to testify today and coming to the table, you'll need to fill out a white card. Please fill that out. Get that to the Sergeant at Arms. They'll return it to me. One important note, we must maintain decorum and respect. Some of these issues can be invoke a lot of passion, so we will maintain decorum and we will be respectful. The whole goal with this hearing is to find truth wherever it lies. So we're going to continue to carry out what we started yesterday with the second day. I want to thank all the doctors and some of the speakers who wanted to come yesterday for coming back. We appreciate your patience with us. So I'm going to make sure I go through everything else. There are no cell phone, there are no pictures to be allowed taken in the conference room. In case you didn't know this whole proceeding will be aired online. It is streaming right now. You can access it at any time. So again, please abide by that rule rather. No cell phone pictures. We do have lots of witnesses today. I'm going to try and not to invoke any sort of time limit because I'd like to see everyone have their fair share of time speaking with maybe some questions. Those coming to the table that have been invited from the state agencies and associations, please give us only 5 minutes for opening statements and then we'll open up to questions. Time permitting, we may break for lunch, but that will be dictated by how many cards we have. We are starting to get a few cards that are coming in, so we'll decide how that works out. But for right now, we're not going to invoke any sort of time limit. With that, we'll get on with today's agenda. First at the table, Dr. Ralph Abraham, the state's Attorney General. Sir, please introduce yourself and maybe just a slight background.
Thank you, Mr. Chairman. Ralph Abraham, current Surgeon General of Louisiana. To my immediate left is Dr. Wyche Coleman, our Deputy Surgeon General. I've been asked to provide just a brief background. Go ahead.
A little closer to the microphone,
Okay.
Dr. Abraham.
So I've been a practicing physician for now a few decades. Was a member of Congress for 6 years. I was Secretary of LDH for a short time after Governor Landry appointed me, and then we moved into the Surgeon General position. In the last 4 years, as far as the COVID pandemic has taken place, I would conservatively guesstimate that I've treated over 15,000 COVID patients, from the very minor with the runny nose to the very severe where I do CAT scans of their chest and 80% of their lungs are whited out with what's called a ground glass appearance. So, Mr. Chairman, thank you for the opportunity to testify before me today. I'm going to read from my prepared statements, and then I will certainly welcome any questions. And I do expect many questions will be poised regarding what I would have done differently during the COVID pandemic had I been head of public health. The short answer is just about everything. There has been ample time to reflect on these questions. Upon retirement from Congress, I immediately returned to full medical practice. primary treating COVID for the better part of now 4 years. It's been my observation that nearly every intervention attempted by government has been ineffective, counterproductive, and unethical to the core principles of a free society. Mask mandates, lockdowns, forced closures of churches, schools, and businesses, coerced vaccinations, and suppression or intimidation of those who resisted are just a few examples of policies endorsed by the previous administration, which I opposed then and still oppose now. Not only because the policies were practically ineffective at achieving the stated goals, but primarily because they violate constitutional protections guaranteed to all Americans. Medical boards threatened providers who did not go along with the mainstream narrative. Pharmacists refused to fill valid prescriptions for repurposed medicines written by licensed providers. Federal authorities restricted the use of monoclonal antibodies just when we needed them the most. We were extremely fortunate to have Governor Landry as Attorney General at that time to provide a very strong counter to these tyrannical forces. As a primary care doctor, I supported him in his efforts then, and as Surgeon General, I support them now. This experience has brought into focus forces that have been progressively eroding the doctor-patient relationship for a long time. Collectively, we can call them third-party interests. Pharmaceutical companies, insurance carriers, and government are a few examples. Their primary interest is something other than that patient getting better. That is not to say they don't want the sick people to get better or that their intentions are all malicious, but only that their first goal, by definition, is not patient-centric. They want to sell a product, increase the stock price, push a political agenda. These third-party interests have inserted themselves between the doctor and the patient for their own benefit and to the patient's detriment. In many cases, it seems that they have hijacked public health to be their marketing legacy. A recent survey showed that trust in doctors had declined from 70% in 2020 to 40% in 2024. The cause is not a mystery. People have been repeatedly given bad advice, and they know it now. Public health was a major source of this bad information. In order to regain their trust, we will have to do something radical, and that is simply tell the truth. A glaring example of bad advice from public health was the promotion of COVID vaccines for kids. It was known early on that disease posed nearly zero risk to healthy children, and that the real risk of harm was associated with the vaccines. In medicine, risk-benefit ratios guide our decisions, and in this case, risk always outweighed any possible benefit. Parents knew best, and less than 5% chose to vaccinate their kids under 5. Still, pressure was applied, marketing gimmicks were employed, and in defiance of all reason and logic, some continued pushing it to this day. These efforts are not increasing COVID vaccine uptake in kids. The only metric changing is trust and doctors in public health. The prevailing justification for this practice was to protect the elderly, but we should be reminded that in a moral society, adults make sacrifices for the benefit of the children, not the other way around. To chart a better course for the future, we must return to some very basic principles. First, do no harm. This simple idea originated from the Hippocratic Oath, reminds us of our primary duty as physicians, and I believe it equally applicable to public health. When in doubt, choose freedom. Science as a whole is defined by lack of consensus. Our goal should be to provide the most accurate and up-to-date information possible and facilitate debate and discourse in the search of truth rather than suppress it. Despite the laundry list of mistakes made in the past 4 years, there is much cause for hope going forward for Louisiana. Legislation passed last session has taken several significant steps toward limiting third-party interests in medical decision-making. I look forward to working with you all in the next session to further those efforts. Secretary Harrington and I are in lockstep in our commitment to meant policy at LDH that focuses on restoration of the patient-doctor relationship. There are many great people at the agency working hard to move healthcare in a positive direction for our state. I would ask for some patience and understanding that the Department of Health is like a huge ship with a tiny rudder. Rest assured, the wheel is turned now to full deflection, but results will take some time to fully come to fruition. At my core, I'm an optimist about the future in general, and especially the future of Louisiana under our current leadership. I appreciate the time you've taken to lead these hearings. It has been said that the main lesson of history here is that we learn lessons from history. This is our opportunity to break from that trend. I hope we seize it now. Thank you, Mr. Chairman.
Thank you, Dr. Abraham, for that. I appreciate your candidness. I want to say thank you for your honest testimony and your honest viewpoint from being a treating physician yourself. I think those things need to be said, so we all thank you. Were you a treating physician during COVID?
Yes,
How many did you treat patients with COVID?
I did.
How many would you say you treated?
Since the pandemic started early 2019, as of current, in the neighborhood of 20,000 COVID patients.
Have you lost any patient to COVID?
I have lost them.
Can you give us a percentage on the number that you've lost versus those who you treated successfully?
It depends on how you define lost or where you define lost. Certainly, patients that I had that went into a hospital situation, some unfortunately did not come out that were placed on the ventilators. Those that I treated inpatient or in my clinic, I don't know if that I lost any.
Can you repeat that?
I said I want to give a very truthful and honest and reflective answer. But those, and we had some very, very sick patients that had faith in us, faith in our clinic, where at one point it was only my daughter, myself, and my wife that were operating the clinic because everybody else we had basically sent home. I don't remember losing a patient that we treated in the clinic.
What do you attribute that success in clinic to?
Just common sense. We saw early on what worked. We certainly saw nationally what didn't work. The basis of medicine is science. You fall back on your training, you fall back on your education, and in this COVID pandemic, you had to reach way back to the first year of medical school and remember your physiology, your biology, your biochemistry, at how those cells in those lungs reacted to this particular virus. COVID certainly was a virus of infection, but more predominantly, it was a virus of inflammation. You all here have read about what is called cytokine storm. The cytokines are chemicals that are released in the bodies that take an insult that produce severe inflammation in the body. COVID, not 100% targeting the lung, but certainly the lung was the main organ that it impaired, and that's what caused death in most cases. The heart was also impacted. When I would do CAT scans on my outpatient patients that we treated in the clinic, there were patients where we would get results back from the radiologist where 60 to 80% of their lung volume were inflamed and infected with what was called by the radiologist a ground glass appearance. That's the inflammatory component of COVID. Oxygen exchange was greatly impaired, and that's where COVID did its worst damage.
Can you share with us some of the early treatment that you used on your clinic patients?
Yes, we were one of the clinics that would certainly prescribe pre-disposed or off-labeling the ivermectin, the Plaquenils. We knew that the inflammatory component of COVID had to be checked very quickly to prevent that cytokine storm that had already occurred, or to at least suppress it. So you go back to your biochemistry. Why were these drugs being used in lupus? Why were these drugs, certainly Plaquenil, used in other instances? If you look at those two drugs, specifically the ivermectin and the Plaquenil, they are strong anti-inflammatory drugs. Early on, the CDC recommended not to use steroids in our patients. I never stopped using steroids because they have also a very strong anti-inflammatory component. What we noticed, and we would bring these patients back sometimes 2, 3, 4 days in a row to treat with some steroid injections. Certainly we cover the secondary infections with an antibiotic, such as Ithromax, because it also has an anti-inflammatory component along with being an antibiotic. But we would see improvement day to day. And again, I cannot stress how sick some of these patients were. They literally put their lives in our hands. And, you know, great faith, we just could not let them down.
Very good, Dr. Abraham. I'm going to ask you one more question, then I'm going to open it up to some of the members. If you were able to create early treatment, how come there weren't more doctors who were engaging in early treatment and perhaps preventing some of the hospitalizations and the eventual placement on ventilators for some of these patients?
I think a lot of it was fear from retaliation. I know that I got to the point in my practice where I would write a prescription of, let's say, ivermectin, and I was getting to the point where certainly the big box pharmacies and some of the local pharmacies were not wanting to fill it. And that's where I give huge credit to our current governor. He came in and said, no, you're the doctor, you know the patient, do what you need to do to save patients. In response to his letter that he wrote to the pharmaceuticals or the pharmacists, they backed off, and we were able to move forward to a point. We, in my opinion, were getting misinformation from the CDC. I'm not sure, I don't think it was malicious, I hope it wasn't, but I think that really no one knew how to treat this particular viral particle. I go back in history. I read a lot of history, and there's a book called The Great Influenza written by John Barry about the 1918 flu pandemic. The particle size of a COVID virus is almost identical to the particle size of an influenza virus. The COVID virus, if my memory serves, is something like 0.1 micron, which is 100 nanometers, if my physics is right. A flu virus is 80 to 120 nanometers, so they're basically the same size viral particle. Go back and read that book. Mask didn't work then. We knew they wouldn't work now. Whoever came up with the 6-foot rule, I mean, you know, I won't use a derogatory term in a public setting, but
well, it's been determined that was a made-up abstract distance.
This is a viral particle so small that I'm sure there are particles in here right now. It floats in the air, so 6 foot was ridiculous. So once we saw that type of information coming out of the CDC, it just simply made no sense. To your question, some providers, healthcare providers, took CDC at their word. And, you know, I understand that. You want to be able to trust your government. That's what government is supposed to do, is give you good feedback and give you good information. Again, I don't think it was intentional. I just think nobody knew how to handle this particular situation. But that's where common sense comes in. And that's where, in my opinion, that relationship between the patient and the doctor, to me, is sacred. And it should not be divided by anyone.
Yeah, yesterday we had some testimony, and one of the takeaways for me personally was that we need to exercise a little more autonomy as a state act perhaps a little more independently. Back to the CDC, they gave information out that wasn't accurate. Now, we're not in here to decide what the motives for the CDC, but at the end of the day, it wasn't good information.
I agree with that. And to your point, I totally agree with the autonomy. And to my previous point, I think we've got a leader now that understands that and will back us up on that.
Very good. Okay, I'm going to turn it over to some of the committee members. Representative Vice Chair Owen.
Thank you, Mr. Chairman. Thank you, Dr. Abraham, and thank you, Dr. Coleman, for being here with us today. You mentioned interference from the state in the practice of medicine. Would you call it significant? Did you shake it off, or?
Well, we got interference from some of the pharmacists that certainly. Now, from the board itself, I'll defer to Dr. Coleman. He's a little more versed on this particular issue. He and I have had extensive conversations. But there were some issues with certain providers, with the board that were, again, practicing medicine the way they thought it should be practiced. And again, that's their prerogative as physicians. Take it from there, Doctor.
Yeah, I think the national boards were more.
Doctor, let me introduce. Can you introduce yourself?
Yes, I'm Wyche Coleman. I am the Deputy Surgeon General, doing what Dr. Abraham tells me to do. I think the national boards were more of a problem, like the internal medicine boards. They've taken a few people's licenses who are pretty high-powered people recently, are taking away their internal medicine board. I think the state board was less of a problem. People did receive letters, and I think that had a chilling effect on speech.
Where I'm going.
Here's just an interesting story is, for a while, COVID was pretty scary at one time, especially during the Delta wave. The hospitals were full. People were dying in droves. And my dad, he's a primary care doctor doing just about the same thing that Dr. Ralph does over in Coshada. And I would call him maybe twice a week and say, did you have anyone hospitalized? No. Did you have anyone die? And they're seeing maybe 50 COVID patients a day at that time, given a lot of monoclonal antibodies, given a lot of early treatment, and backing it up with monoclonal antibodies. And the answer was always no. And I'm amazed because the hospitals in Shreveport are totally full. And I said, you guys have got to publish something on this and tell about this. And of course, my dad said, well, I don't want to lose my medical license, so I'm not telling anybody about this. So I think there was already a chilling effect. And he's a 70-year-old guy. He's not too worried about that. But he didn't want to end up in a situation where he was under duress and not able to continue treating patients. So I think that the implied threats, there was some people who got letters. I think that the implication of the threats definitely had a chilling effect on speech, and that's the reason everyone wasn't using early treatment. They were scared to.
Well, what I'm really driving at is Dr. Abraham, have you in your medical career ever seen that? Has there ever been another time where you even heard of it, of a state licensing board stepping in and threatening people with licensure harm if they're caught spreading misinformation? I mean, it's not. They were almost being accused of witchcraft.
To your question, Representative, no, I've never. Never before.
And it's just breathtaking to me. And I have a lot of colleagues here who want to ask questions, and I will defer to them. But I will tell you all this. I would ask. I have forwarded some questions in recent weeks regarding the topic of emergency use authorization, and I've sent them to LDH, to the Board of Pharmacy, to the Board of Nursing, and going forward as we move towards legislative ideas for next year, it has occurred to us, those of us who have been forced to learn what emergency use authorization was when the pandemic happened. Most of us had never heard of it, and then when we started drilling down on it, so why aren't we doing this? And now to find out, when I ask the question to these four agencies, everyone stands in a circle and points right. And there's nobody saying, yeah, I've got this, I understand this. And it seems like it's pretty serious. And it seems like something that we need to look into.
It opens up a very potential abuse of power.
That's what concerns me. And for those listening who've not heard of this, my layman's understanding is of emergency use authorization is the government comes down and says, okay, whether it's this shot or this treatment, not necessarily fully authorized, but we're going to give it under an emergency use because we think it's good for the public health. But then it is incumbent upon the people that are administering health, whether it's the doctor or the nurse or the person at Walgreens who are sticking a shot in somebody or telling them to use a mask, that this is an emergency use thing and this is an experimental procedure. We need to know that. I think as citizens, I think that's something that we need to pay attention to. I think that's all I've got. I'm going to let my colleagues ask questions, but I want to thank you, Dr. Abraham, Dr. Coleman. Thank you for your frankness. Thank you for saying what you've said, and thank you for your service and your bravery during COVID. And that was a hard time for physicians. I know y'all were exhausted. You were spent every day, and just want to say thank you, and God bless you.
Thank you.
Representative Knox.
Thank you, Mr. Chairman. Dr. Abraham,
Good to see
Dr.
you, sir.
Coleman, thank you for being here. I have a couple of questions, but before I go there, I want to thank you for maintaining some decorum and not using certain words. And I know you had some constraints to do that. I'm not as good as you, but I will try. And I want to preference by saying yesterday was very enlightening to me because I came here intentionally to have an open mind. Prior to coming here, I had the notion that there's a bunch of wacky people who are anti-vax and who are anti-government. But I will say, and I will submit that since yesterday, and I went back and reviewed my notes of those discussions in great detail, and I'm very enlightened. And the people who came before us yesterday, they didn't, in my estimation, seem wacky. They seemed to be very articulate, very intelligent, and knew their subject matter. And they didn't put the political spin on it. They provided, to me at least in my observation, the facts. And they even put counterfacts to what they were presenting to us, which I greatly appreciated. And so I said all that to lead into some of my questions. You mentioned early on that you would have done almost everything differently. I am a small business owner, so one of my questions would be, and you kind of alluded to your opinion about the social distancing, the 6 feet thing. Can you, and the mask, can you elaborate a little bit more on why that is? And I appreciate you said something to the effect that that was something that was just pulled out of the air. Basically, it wasn't based in any real empirical data to come up with 6 feet or any kind of feet and the mask. And in your elaboration, could you answer whether or not you would have been inclined to shut down all businesses? Because it was very bizarre to me why some businesses were left to be open,
Exactly,
and others not.
Yeah, it was very
and
nice.
if this is something that's so contagious, how is that helping or controlling anything?
Well, Representative Knox, let me preface what I'm going to say. You know, I learned in Congress, and certainly knew before, that when there's something that probably should just be left done, government, certainly federal government, they want to do something to look like they're doing something, okay? But that doesn't work in most cases. So I would not have shut businesses down. I would not have closed schools. I would have let that doctor-patient relationship flourish. If that doctor and that patient decided you don't need to go to work, you don't need to go to school, that's a decision they need to make among themselves. Now we can look back 4 years at the history, and did that save lives? I don't think so. I think it may actually have increased mortality because we did mute to a point the virus itself from getting at lower levels in people's immune system and creating that natural immunity, which we know compared to the vaccines now is much better than vaccine immunity, because this virus, we're in an Omicron variant strain now. I think it's called K311. They just named these things. I'm sure there's some rhyme or reason that I don't know. But we're into a vaccination push now by the federal government. You see it on your TVs. You see it in your papers. But they're telling us that in another month, you're going to need another vaccine. And then maybe 2 months from there, another one. So medicine has its own way of working its problems out. And the body is an amazing organ that can defend itself when it must. Would people have died? Sure they would. This was a bad, bad virus. But my question that I asked to the highest levels of our federal government that I've yet to get an answer, would the mortality have been less if we would have been more pragmatic, more common sense approach, more patient-doctor oriented, and go from there?
Thank you for that.
Handle this, Wyche.
You mentioned that in 2020, trust in doctors was 70%, and now is at 40%. I think I'm kind of somewhere within the 40%, to be quite honest.
And I understand that. I mean, I empathize with that.
I don't like that feeling.
No, I don't either.
I don't like that
I'm
feeling.
with you.
And it concerns me because I heard it yesterday, and I had a sidebar with one of my colleagues along the subject where pharmacists did not write the prescriptions of doctors. And for me, as a layperson, and I consider myself a layperson, that's very strange and wacky to me. I'm trying to understand what is the thought process of a pharmacist not writing a prescription,
But not filling it, you mean?
filling a prescription for a doctor.
Well, I love my pharmacists, the local mom and pops. They're phenomenally trained, phenomenally intelligent, and they were the ones that were, when they were hesitant, they were getting pushed by the feds not to fill because they were fearful of their license as shutting their businesses down. The difference as far as physician training is we, as the pharmacists do to a point, we have the biochemistry, the physiology. We understand the process that goes on inside the cell as to its response to a particular insult. And when I take all that into consideration, if you're my patient and you come in with the high fever, the cough, all the things that COVID presented with, and I reach back in my brain to my first and second year of medical school, and I pull all those things together, and then I make a decision, then as a physician, I expect my prescriptions to be honored. If I didn't have the training to pull back on the resources, you could give me debate. But until you've had that exact training that I've had, or that Dr. Coleman has had, or any physician has had, then please give us at least the benefit of the doubt that we are doing what we know is the best for our patient.
Yes, sir. And I appreciate that. I'm just trying to understand, and maybe those who are watching may want to understand as well. Why would they not fill the prescription?
Well, I think their ability, the pharmacist's ability to not fill a prescription is based on, the idea that maybe if we write 1,000 milligrams when we meant to write 10, then they would have the ability to stop and say, I don't think this is the right dose. And that's a good check and balance to have in there. Or if they, have some moral or religious grounds, I think that there could be some of those on the abortion debate where they say, I don't want to fill this for some moral or religious reason. Fair enough. But the off-label drug use question is one that came up in, I believe, one of these sessions earlier this year, and that's a long-standing principle. So the FDA approves drugs for like a very narrow use. For example, I do cataract surgery, a lot of cataract surgery, and we use drops after cataract surgery to prevent infection, control inflammation, et cetera. None of those drops are approved for that purpose. They're approved for other purposes, and then they're repurposed for the use of controlling inflammation after cataract surgery. In ophthalmology, probably like 90% of the drugs that I use are not approved for the purpose that I'm using them. So that's a long-standing principle, and that principle was then, which they would normally fill all that. I think because it did not go in line with the prevailing narrative of that's when they said, for a political reason, I'm not going to fill these prescriptions. And that's where it's so problematic, because if that's the precedent, well, maybe they decide that they don't like filling drops for cataract surgery one day because it's off label, and they could stop that from happening, which would not be good.
So if I am the patient and I have this relationship with my doctor and I go to the pharmacist to get my prescription filled, where does that leave me when they decline to
In
fill
a
my...
precarious
It
situation.
leaves you in a very bad bind.
So yesterday we discussed budesonide, if I'm pronouncing that
That's
correctly.
right, budesonide.
Is that something that you all see as early treatment that has been successful?
Yes, absolutely. Budesonide is an inhaled steroid, and it was used in nebulization treatment, and it did work.
Does that work to the point that you were mentioning as to COVID is also inflammation?
Exactly. That's the reason it does work.
That's the reason it does work.
Because of its anti-inflammatory component, being a steroid drug. Steroids being anti-inflammatory drugs. If you wrench a knee, if you throw a shoulder out, you get a steroid injection because you got inflammation in that joint. In COVID, you had just significant and severe inflammation in the lung field.
So and I'm wrapping up. Can you explain or give an opinion as to why simple people like me did not hear more about this treatment and COVID being as an inflammation type disease? Because from my appreciation, I akin it to a flu, a very serious flu, and therefore it's infection, and we should focus on that. I don't recall, and I'm sure it may have been said, that there's an inflammatory side to this pandemic that we're experiencing as well. But I don't recall hearing a lot about that side of this disease.
It was top-down control of the narrative, and that did not go along with it.
There were studies that would come out that I would catch one day, they would be up, that would go to that narrative that there are good things that can be done with these particular off-label drugs. The next day I couldn't find it.
Thank you. And so for inflammation, you would not have to social distance for that, correct?
No, that's correct. That's a good point.
Could you humor me for 1 second? I was just going to, you talked about, the idea that there were some quacks, and I think that's how a lot of people were portrayed for a while. I read this Michael Crichton quote. I thought he was a great author, but he wrote that the greatest scientists in history are great precisely because they broke with the consensus. There is no such thing as consensus in science. If it's consensus, it isn't science. If it's science, it isn't consensus, period. So pretty much every great idea in science was come up with by a quack at some point, until everyone figured out they were right.
Thank you. Thank you, Mr. Chairman.
Representative Edmondson.
Thank you, Mr. Chairman. Thank you, gentlemen, for being here. It's great seeing y'all. So good to hear common sense. You just have no idea. I am, and I've had conversations with both of you. I'm interested in the healthcare workers and the adults that have been forced to take the shot and have not wanted to do it. I have a simple question. Would y'all support legislation to take care of our healthcare workers and the employees in our state that have been so, to me, wrongfully just pushed into something that was so against everything they believed in?
Absolutely. I see now vaccine injury every day of my practice. Whether that's an arrhythmia, whether it's an atrial fibrillation, whether it's a myocarditis, whether it's a vasculitis in the lower extremities. And we're learning because these studies, again, that were suppressed are starting to finally be shown some light. Yes, to your question, would I support, but know that you're going to see going forward a lot more of the vaccination injuries. If you look at VAERS, the Vaccine Adverse Event Reporting System, and again, I think I'm right on my statistics. You can check, you can fact check it. But in the last 4 years, that the reporting of adverse events from the COVID vaccine specifically have gone up almost 2,000%.
Wow.
You have something to add to that?
That's correct. Yeah.
Okay.
It's unbelievable. And my only other, it's really not a question, it's a comment, but I think I know how both of you feel about the doctor-patient relationship. That's very important to me. You know, we had a bill last session that didn't get through, but we will be bringing it back that has to do with off-label drugs. And I don't know if it was assumed we were talking about some drugs in particular, but Dr. Coleman, you have a great example as an ophthalmologist with all of your drops that you use that are really, off-label. And so why in the world would we not, would we not want that?
It's a little bit mind-blowing that even comes up in legislation for something that is a long-standing, well-established principle. It seems that based on the experience of the past that it may be worth protecting it with legislation, but I think it's the default position. I think anything other than that was a big deviation from a long-standing precedent.
Well, to me, that's really what happened with this whole pandemic or supposed pandemic, is we destroyed so many of the traditional things that have been good for us. The doctor-patient relationship, off-label drugs, destroyed because of information that was incorrect. So I just appreciate both of you and thank you so much. Dr. Abraham, were you going to say
Yeah,
something?
I just want to add to what Dr. Coleman said. In America, it's such a problem and such a arduous process to get a drug labeled for a specific cause. The manufacturers of drug companies, they know this drug is useful and beneficial for so many other things, but to go through that process again, spend hundreds of millions
Right.
of dollars, they're not going to do that because they know as docs, we're going to use it for the right thing anyway. There is misperception in this. I truly, in my heart of hearts, believe this was a federal issue from top down. They tried to make the term off-labeling toxic. They did not explain, because they didn't want to explain, because they didn't want us to use those
Right.
off-label drugs on our COVID patients, what it actually was. Had the general public
Understood.
informed,
I agree.
we would be having a completely different conversation.
Yes, sir. I agree. Thank you so much, both of you. Thank you, Mr. Chair.
Representative Amade.
Thank you, Mr. Chair. Good morning. Dr. Abraham, your comments have been completely refreshing today. I intend to go back and watch the video and maybe transcribe them and share. So thank you. I have a couple of questions. During the pandemic, when the former governor would come on and do press conferences, the end of the report was always about how hospitals were over capacity. And so many times I would be contacted directly or indirectly by hospital staff saying, hey, I work at that hospital and we are not even at capacity. And often on social media, people would drive by certain hospitals and see there was no line, there weren't cars. So surely we had some hospitals that did max their capacity, but I think that it was exaggerated, and I'm being kind by using the word exaggerated. So my question to you is, in the event that hospitals were over capacity due to COVID patients, are you aware of how often that might have been simply self-inflicted by having staff shortages?
I am not aware of what that number is. I understand that I understand it the same way you do, but as far as giving you a number or a percentage, I just don't know.
Okay. I don't know that we'll ever find out, but it was interesting to me that while certain staff were being fired because they refused to take a certain jab, hospitals were screaming that we're understaffed, and it's like, yeah, so I'll leave that one alone. Has there been any effort, or will there be any effort, to review the death records and correct the statistics so that we have an actual accurate report of how many in our state died from COVID versus died with COVID?
I hope so, yes.
Good. So somebody's moving on that? You're pursuing that?
We are. Yes, I don't know where we're at in the states, and again, that's also an arduous process.
Oh,
But
sure.
we want to be completely transparent at our level.
Thank you. I appreciate that. When a person dies who recently had a COVID shot, or actually any other immunization for that matter, is this considered at all in the autopsy, or is it noted at all in the autopsy report?
Not to my knowledge.
Okay. Do you have any experience with vaccine injury?
I do.
Good. Would either of you like to talk about that for a moment? What's your experience with vaccine
Well,
injury?
As I mentioned just a little bit ago, everything from heart-related problems to skin-related problems. There's all kind of issues with some dermal issues. Vasculitis is a big deal. Guillain-Barré is certainly a known result of COVID vaccine. And there are many others that are kind of outliers, but you get a patient that has never had what I would consider an odd issue that presents to your clinic, and you're scratching your head and you're trying to figure out why this particular patient has this particular oddity. So you do the history and the physical, and you go through the motions of what we do as docs. And the only commonality is they had a COVID vaccine. You think that? No?
It might be worth you commenting on, drawing spike protein levels in your clinic. I don't practice real medicine. I just look at eyeballs all day. So these guys are the real doctors. I realized how unessential I was in the midst of the pandemic when I was sitting at the house talking to them about how it was really going. But, you might want to comment on that. I think that's an interesting point that's come up since the test is now available.
We have the ability now to test for the spike antibodies. And when I have a patient that comes in with what I consider could potentially be a vaccine injury, I will run a spike protein level, and sometimes there'll be the test that I use, I think, is a Houston lab. And the test only goes to 25,000, whatever that number is. And hundreds, if not thousands, of patients that I do the spike protein levels on that have vaccine injury, their numbers are greater than 25,000. They could be 100,000. I don't know. They could be 25,001. All I know is that they're greater than 25,000. So that gives somewhat of a qualitative aspect to it. Now, will you get spike protein antibodies with the disease itself? Yes, you will. Are they as large as those that have had the vaccine? I can only speak from my experience, and I've seen no other studies that will either deny or affirm what I'm fixing to say. But in my own little clinic, those that I have the vaccine injury patients, their spike protein levels are in general much greater than those that actually went through the disease.
I see. Is there treatment for vaccine injury?
There is some that is being marketable as that. Most of them are amino acids, some supplements that what they do is they kind of kick the immune system in the hiney and say, hey, get to work and let's see if we can push back on this. As far as any licensed pharmaceuticals, to my knowledge, there are not at this point.
Thank you. I was looking more for protocols.
Yeah.
I hear some things like detoxing.
I use a protocol.
Good.
And, the way we do it is we will put them on this particular protocol, and I will bring them back in 4 to 6 weeks, and I will remeasure that S protein, and they're usually lower. So
Good.
I know something's working.
Good. So there is hope. Last question. Why did the Department of Health promote COVID shots under EUA as FDA approved? And what are the legal ramifications for Louisiana consumers or patients?
Yeah, Rep, I don't know.
I know you weren't there.
To both of those, certainly not an attorney. As far as the legal aspect, we weren't there then. Again, in my opening statement, I would have done it differently, but I just don't know that answer.
We'll ask some certain people in the future if we
Okay.
can get them in here. Thank you for entertaining my questions.
Thank
That's
you.
all, Mr. Chair.
Representative Cruz.
Thank you, Ms. Chair. Secretary Abraham and Assistant Secretary, Secretary, Surgeon General Coleman, thank y'all for being here. What you said in the beginning was so encouraging to me. I've kind of got to bring my focus back here. You said, when in doubt, choose freedom. And that meant the world to me, and I think to most of Louisiana. The preamble of both the U.S. Constitution and the Louisiana Constitution emphasize liberty, and I'm glad you brought that to the fore. That's very important, and I'm so glad you said that.
And Rep, I always give credit where credit is due, and I plagiarized that from Dr. Coleman.
Great job, Dr. Coleman. I was in health and welfare during this, so I heard this regularly, and it was very disappointing, the attitude that the state was taking as more of a parrot for whatever the CDC said instead of evaluating this. And it brought to mind something I brought up yesterday, and this is Thomas Sowell, a famous economist, used to say anytime we had any policy proposal, we should examine three questions, ask these questions. Compared to what? If we do something compared to not doing something or doing something else, at what cost? What is it going to cost us for implementing whatever this policy is? And what hard evidence do you have? And I felt every one of those three questions, some of these countermeasures, was not asked and was not answered. I mean, some of them, let's say masks even did work. What was the cost of that working? I mean, a lot of people have brought to the fore that covering the face of the kids in school and their teachers was antithetical to teaching in that relationship and how they understand expressions and emotions. So we didn't examine these three questions, and I think we should in the future, and I'm so glad you're here to talk about these things. I did want to ask you one question about the chilling effect that Representative Owen brought up there in hospitals. So a patient or a doctor that's working within a hospital situation, do you know anything about how that relationship was and what expectations were of the hospital systems on those physicians?
On some local level, I do. Unfortunately, even we as private physicians, it would literally take almost an act of Congress for me to see even a patient of mine that had gone through the emergency room and is when it was in ICU because they had these quote unquote COVID wards. And I mean, it was almost an armed guard situation. I got to some of my patients by being brutally frank and aggressive at times, not physically, but just pushing the envelope that said, these are my patients, I want to see them. But I got pushback from the hospital. To Dr. Coleman's point and my point earlier, a lot of these hospital doctors that I knew personally, they feared for their livelihoods if they went against the federal narrative. They wanted to do things, and the question is, why didn't they? That's a question that I can't answer for them. But I've had conversations with several, and they were basically told that if you don't toe the line that's coming down from the CDC, your history.
And do you think some of that was based on maybe financial incentives or something? I'm trying to figure in the mind how they made their decisions and why the hospitals may have pushed certain attitudes or agendas.
Come in.
I think early on everybody was scared. It was a pretty scary deal.
Sure.
It's easy to Monday morning quarterback now in 2024, but in 2020, it was a scary deal, and the hospitalists, my hat's off to them. I mean, it was a rough situation where they were short-staffed and they were taking care of a lot of really sick people. So the idea that it was a hoax or something like that, I mean, you hear that push. Well, that's counterproductive too, because this was something new. People did really get sick, and I think they were doing what they could to survive. And with all the measures, like this is not specific to the hospital, but masking, 6 feet of social distancing, various things like that. It's not such. I'm sympathetic to people who said we want to do something. We want to do something to try to improve the situation. But when it was obvious that it was doing nothing, doubling down was the problem. Should have fallen back to that idea that let's go back to freedom now, when we know that this is not working.
We had some interesting testimony yesterday. We're going to hear some more today from Dr. Grow, who was volunteering at a shelter and had some 3,000 guests that weren't social distanced, didn't wear masks, weren't vaccinated largely. A few of them were, she'll talk about. And yet they were better off than the population that was doing those things. And it made me think of an old story where this old airline pilot getting ready to retire has a news reporter in the cockpit for the last flight, wants to ask him questions and how'd he make it 35 years or whatever it was. And he goes, I'm sure you've had these problems, engine problems, maybe fire, hydraulic. I go, oh, yeah, I've had all those over my career. He goes, well, how did you manage this to get 35 years without a single accident? And he goes, well, whenever there was an emergency, the first thing I do is wind my watch. And the reporter was like, wind your watch? That makes no sense. Why would you do that? He said, well, as far as I know, no one ever killed anybody winding their watch.
That's right.
So I'm trying to say, in a lot of cases, it sounds like doing nothing might have been better than some of the things we did do. And I like your approach. When in doubt, choose freedom, Dr. Coleman, passing it on to Dr. Abraham. I think that's a wise choice, and I think in the future, I think that's going to be a great attitude. I hope LDH will take that on too. I did want to ask two more quick questions. Dr. Abraham, did you personally have any criticism or retribution from the Department of Health or the Board of Medical Examiners?
I did not.
Okay. And if you could, a lot of people here, when they hear steroids, they think of anabolic and people going to work out. Could you clarify the steroids that you're talking about?
The ones that we were using, and still I use them daily in my medical practice, these are not the anabolic steroids. These are the steroids that are anti-inflammatory in nature. They don't bulk you up. They take inflammation out of your body. So, apples and oranges for sure.
Okay. Well, thank you very much. Thanks for being here today.
Representative Tarver.
Thank you, Mr. Chairman. And thank you, Dr. Coleman and Dr. Abraham. I want to ask I got some very different questions, but I'm curious about, this was kind of posed to me in a fashion. During the early months and throughout the next 12 to 18 months of COVID, there was ivermectin, and one of the roles and responsibilities of the Department of Health is to protect us, correct? To protect the public. And so there was a lot of emphasis on ivermectin and forbidding the use of it in order to protect, I guess. But there's also another rampant drug, fentanyl. And I'm just curious about where the emphasis was during those days, and maybe even still is, about protecting the public. Which one do you think is kind of more important? Which one was given the most emphasis at that time? Because there were a lot of people who were suffering, families suffering dearly with the fentanyl. And I'm not talking necessarily about the illegal drugs. I'm talking about families who got hooked on drugs, who got hooked on fentanyl, and you know what I'm talking about. Where's the priority? Because we talk about cost and benefit, and can you speak to what's more important? How do you decide which battle to fight?
I can only speak from personal experience, Representative. Let's go back to history. Ivermectin is an older drug now, been out a long time. Worldwide, it has been used extensively. It has basically cured river blindness in children in other countries that we fortunately don't have here in the United States. It's life-changing. The point I'm trying to make is that the ivermectin is a drug that has a good history. And there has been so much use of it worldwide that the studies have shown it to be very safe for a long time. Now, of course, on the other end, fentanyl is like a gunshot wound to the heart. It's going to kill you.
Well, it has some good uses too, though. I mean,
it does in
like
the proper setting. It is a pain control medicine that, if some of the, and everybody here, I'm sure, can touch it or knows of patients that's been touched by certain cancers. And some of the most horrific pain that I've ever seen a patient is bone cancer. And certainly a fentanyl patch on that patient is both humane and needed, and it does work. To your point of why the federal government prioritized demeaning or degrading ivermectin as opposed to kind of putting fentanyl on the back burner.
That's my question.
Yeah, I understand. I can give you an opinion. I can't back it up with any fact because nobody will give me a fact because we know the answer. I think I know the answer was political. And it's so unfortunate because lives and good people died of that fentanyl epidemic as it's still happening.
Moving on, I guess, a little bit, the doctor-patient relationship, and I compared it yesterday to attorney-client relationship. You're in favor of that, correct?
Absolutely.
And I think the question was asked if we had a bill or a legislative instrument to protect or enhance that, you would help us in that regard.
I would. I've been married for a long time to my wife. She's here. I love her dearly. And that marriage bond is very, very, very important. But I will debate you that the patient-doctor bond is it should be a tighter bond. My patients will tell me things they will not tell their spouse because they know I'm going to keep it confidential. They know I'm going to help them with whatever problem they had. So for me, on a personal level, as strong as my marriage bond is, my patient-doctor bond, I will put it above that.
Let's answer this for me. You're the Surgeon General, and you were the Secretary of the department. What's the hierarchy or the roles and the different roles? Like, what do each of those have responsibility for?
We've got Secretary Harrington and Undersecretary Drew Moranto that are doing, in my opinion, phenomenal work, that are going to oversee the Medicaid, the other issues. As you know, LDH, you've seen the budget, you vote on the budget. It's a big beast. 6,000 to 8,000 employees, depending on whether you count them in town or outside. A huge agency that needs the leadership that Michael and Drew bring on their level. For Dr. Coleman and I on the Surgeon General side, we envision and are already moving in a very rapid pace and to present public health policy that can be implemented by you guys that will change the course that this state is in right now, being at the bottom of the barrel in everything that I consider important: maternal and infant mortality and morbidity, chronic disease, you name it. We need to do a lot better. And that's where I think Dr. Wyche, myself, Bethany Blackson, my chief of staff, Emma, the people that we employ on our side of the fence can move that policy debate and that implementation, I think, in a very good direction. You want to add to that? You've had some good insight on that.
Yeah, I think that in the previous scenario, you had the state health officer.
That's what I was
and that
going.
the state health officer would you basically had the secretary originating policy originated at the level of the secretary. The train had already left the station by the time you had a physician commenting on that policy, and the trajectory couldn't be changed much. So part of the role of the Surgeon General is to have a physician at the top of policy creation, guiding that in a direction that makes sense not just from someone who works at LDH, and I'm not demeaning the doctors who just work there in an administrative capacity, but I think that there's a role for someone who practices real medicine and sees the effect of these policies on a day-to-day basis to be at the origination of them. And I think that we'll have a better practical effect of policy by having him there.
So is this a little bit of a transition or a shift from the way it was prior?
Yes.
A lot. Yeah, pretty big
So
transition.
heading into, we've had some commentary or suggestions in these hearings about the oncoming potential for a potential for an oncoming repeat pandemic type thing, bird flu or whatever has been mentioned as a. So we have a better approach towards dealing with this under this scenario with the Surgeon General and the policy.
We do now.
So what would be some of the things that you would specifically do differently in policy under a new type epidemic?
Well,
Or do you have
why
those in?
the watch? Okay. Pause, think before you just react. That's what happened with COVID. Everybody had such a knee-jerk reaction, got way ahead of their skis, and it got out of control very quickly. And on the federal level, they wouldn't, to Dr. Coleman's point, they wouldn't reevaluate. They were scared to admit mistakes, and so the mistakes continued and they grew.
Will it be easier for you to maybe be a little less, maybe a little more removed from the narrative and the because you develop policy within what's good for Louisiana, and is that going to enable you to be less dependent upon the CDC and the federal issues and all those kinds of things? Not that you won't give them some credence, but you'll be able to analyze what's the impact and what the activities in Louisiana need to be based on our culture and our. I'm not trying to put words in your mouth, but I'm trying to understand where we might be.
Well, I think one place that we could take a right turn where a wrong turn was taken last time is just facilitating debate and discussion between doctors and making sure that they're open to say what they think in real time, because I don't think they were doing it for the wrong reasons. They were just trying to help. And there'll be some people who make wrong decisions then too, but I think that's the way you get to the right decision quicker, is by facilitating speech rather than discouraging it.
Thank you. Last thing I was wanting to ask about was the right to try. Do we have a law? Are you familiar? Do you
I know
if we-
I voted on the right to try in Congress, if I remember right.
That's a federal law.
Yes.
But what about do you know if we have a Louisiana version or a Louisiana law
There is
about that?
I'm pretty sure there's a law, yes. I think that was implemented.
Okay.
You can check, but I'm pretty sure.
I'm
right on
just,
that.
okay, so if it was, and I'm just curious why we weren't able to use it more during the recent years. And like, for instance, with ivermectin, I mean, I should have a right to try that if I understand the law. And I don't know why it was
Well,
rejected
if your doctor prescribes it and you agree with the treatment, I totally agree. You should be able to try it.
All right. Thank you, guys. Appreciate your work.
All right, thank you.
Representative McCormick.
Thank you, Mr. Chairman. Thank you, Dr. Abraham. Thank you, Dr. Coleman. Appreciate y'all being here today. It's a little bit friendly environment than I had the first 4 years in my term here. When we mentioned, we really are, it was fear, and that, I think that has a spiritual aspect, but that's something out of our realm here. But, the people were fearing the government. And personally, I believe we're in a better situation when the government actually fears the people.
That's the way it's supposed to work.
That's right. That's right. And during COVID, it didn't take about 2 weeks for me to figure out, it's the elderly and those who are underlying conditions were at the biggest threats, and those we need to protect the most. I was kind of part of the group that led the rebellion down here against the shutdown, and we had a real radical idea of liberty, and that was, if you want to get the vaccine, get it, and if you didn't want to get the vaccine, don't get it.
Absolutely.
I think that's important for the people in the room to know what liberty is freedom to choose. And but you did talk about the 70% approval rate on doctors down to 40%, and I think that's the tragedy that has actually come out of this. I mean, when we have another situation, we're just going to not trust the establishment, whether they're right or wrong. We're not going to trust them. Kind of veering off, staying on vaccines, but veering off a little bit on COVID. I know there's been lots of testimony in this room about there's not been enough studies to prove whether early childhood vaccines and autism are connected. And I guess my question to you, in the new position you're created, can we pass any laws in Louisiana that can gather information from the doctors to help you do some type of in-state study to determine if there is possibly any connection between early childhood vaccines and autism? Can we do our own study? Is that it's a possibility?
I think so. I mean, Representative Amadi alluded to that. We have the data. We want to access the data. We are trying to access some of the data even ourselves in-house, and sometimes that's problematic. We're working out the kinks, but why not open up the data to everyone that wants to see it, have a discussion, as Dr. Coleman says, have a debate. There's nothing wrong with that. That's the way things get solved, and that's what we want to do from the Surgeon General.
We need that trust back. I'll tell you what concerns me about that is in October 2020, I run a bill saying that you couldn't make the COVID-19 vaccine mandatory. And I was positive they were going to make it mandatory because I did testify. My testimony, if it was wrong, I said there's millions, no, maybe even billions of dollars at stake here, and it was actually tens of billions. So, you know, that drives the train. I knew they were going to make it mandatory, and that was in October 2020. It was voted down, and in committee, you know, they told me I was a solution looking for a problem. And actually, sadly, two of the people that voted against my bill wound up vaccine injured from the COVID-19 vaccine by their own admission under testimony later. Yep. So, but we're talking about our children here when it comes to these early vaccines and these autisms. And, you know, I don't know if this is, you know, I want my children to make decisions based about my grandchildren that are safe. And we need that study. And I think the two of y'all, I know I've met Dr. Coleman at a fundraiser one time, and I've known you, and we trust y'all to make those decisions, and that would be huge confidence builders in building up the confidence in, you know, when it comes to these vaccines. We've even been told that there's testimony several times that the pediatricians, most pediatricians, if you choose not to vaccinate your child, they will not see your child anymore. I know several people that choose to do that don't have pediatricians, and the reason we're given is because they're financially incentivized to have a certain percentage of their patients vaccinated. I don't know if that's right or wrong. Don't even, unless you want to add something, I'm not looking for you to add anything. But
as far as the data goes, for some reason, and I'm new to this game, Medicaid data is held close by all states, and they don't release it. And I'm not sure why it's not just open sourced, de-identified to be HIPAA compliant, and say anybody can analyze it. Analyzing it is like a pretty heavy lift. You need a biostatistician, maybe a team of them to deal with data like that. And of course, you could probably construct a study to reach whatever conclusion you want to reach. So if you do something in-house, you've got the risk of someone saying, well, the results are false because of this, that, and the other thing. So I think that the way to solve that problem, and that's a less heavy lift on the part of the department, is just to open source the data and say, let everybody analyze it, publish in scientific journals on it, and let the chips fall where they may, let the debate happen. I think that's probably the way to get to the truth of just about every matter you could come up with, because we do have a good bit of data. The problem is it's in old software, it's scattered out in different places, and there is a move now to get it localized on a central database. I think Deputy Secretary Pete Krugen can elaborate on that more. The sooner that happens, the sooner you could de-identify it, open source it, let everybody study it however they want to.
Thank you.
And if there's legislation that could help with that, I think we could talk about that in the next session, because I do think it'd be useful.
You bet. That sounds great. Appreciate y'all being here today.
Thank you.
Thank you, Mr. Chairman.
I'd like to enter something into the record, and this is certainly not to second guess you, Dr. Abraham. You are correct. We do have a right to try law, but it's exclusionary to terminal patients only. Okay. My senior legislative assistant, Drew Murray, here has let me know that it was passed in 2014 and is codified as RS 40:116.1. All right, so again, we do have a right to try, but it's exclusive to terminal patients only. Just want to enter that in the record. Representative Egan.
Thank you, Mr. Chairman. I had elected initially not to say anything or ask any questions because I thought you really had pretty much said it all when you presented, and I really thank you for that. Thank you both for that. It's so refreshing. But I am going to ask you to comment on this. This was told to me many times, and the depiction was almost always the same. The messaging to doctors relative to the treatment of COVID patients was, when they present, don't treat the patient, send them home, tell them to isolate, and when they turn blue, then go to the hospital.
And then they die.
And then they die. And that now was said by many people, or at least some version of that. Put another way, doctors were discouraged from actually providing treatment to COVID patients. And secondary to that, then, they were told to send them to the hospital. And my question to you is, was there a deliberate effort made to transfer the treatment of the COVID patient from the physician to the hospital?
I think yes, in some aspects, and in some aspects maybe not, but I think that would be almost on a case-by-case basis as to where that particular hospital was getting their marching orders from. So I do think some of that happened to a point.
Okay. And then, of course, there's a whole other conversation secondary to that then relative to the role of the hospital in treating those patients, but we'll pursue that with other people as this progresses today. Then I want to go on to this letter. I don't know if you can see this letter. It's from the FSMB, the Federation of State Medical Boards. It is a professional expectations regarding medical misinformation and disinformation. Report of the FSMB Ethics and Professional Committee adopted by the FSMB House of Delegates April 2022. And purportedly this was disseminated to the physician community. Are you familiar with this?
I am not.
You're not familiar with this?
I may have gotten it and forgotten about it, probably threw it in the trash if I did.
You probably did, but apparently a lot of doctors got this. And this would have contained a lot of the messaging relative to what the expectations from the doctors were relative to face masks, social distancing, and more specifically, the efficacy of the vaccine. And there's not just an implied threat, there's a very direct threat in here about providing any misinformation, which I would have construed as anything negative about the vaccine was a direct threat to the physician. And I would hope that we would enter this document into the record as well, because I think it underpins a lot of what actually happened throughout the. So if you're not familiar with that letter, I trust you are familiar with the FSMB. Okay, so you did not get the letter. It purportedly went to a lot of doctors, and a lot of doctors actually read it, took it seriously, and that underlaid their response to their treatment of the condition. What I wanted to ask you, is it common for the FSMB to issue an advisory such as this? Is this standard right now? I don't know the answer to this, and usually I'm supposed to know the answer before I ask the question, but
the only way I can represent Representative Egan is that I have never gotten any other letters from them, so that would indicate that they were riding herd, so to speak, on physicians, on other issues other than COVID.
Okay, and that would certainly be our interpretation of this as well. And lastly is, do you know who funds the FSMB and who provides their sustenance?
I could take a guess, but I don't know specifically. But so I won't let conjecture enter into the discussion.
We would probably arrive at the same conclusion with that, but I think it may have had some influence on what happened with this whole thing. So
I agree.
I will leave it at that. Thank you both very, very much.
So Representative Edmondson has promised me she'll be quick. We've got a lot of wood to chop.
Quick, but I will be quick. I just wanted, for the record, Mr. Chairman, to offer that we do have a resolution on studying autism that I have discussed at length with Dr. Coleman, just Representative McCormick, and for the public to know that we are looking at that. I've got a commitment from Dr. Coleman that we're going to do what we can do. We may not have the report at the time that we want, but I have all confidence that y'all are working hard to get the data, like you said, and what we need to complete that report. Thank you.
And I think that one's a real tough question to answer. That it's not a defined endpoint. You know, I think that there's some just subjectivity to the diagnosis there.
Right.
So I think there's evidence that has said vaccines don't cause it in the past. I think that the driving force to relook at it is that, you know, even though there's a lot of studies that have seemed definitive to me, you know, prior to 4 years ago, when I had to re-question whether maybe everything I'd been told in med school was a lie. You could probably fill Tiger Stadium with moms who have kids that were normal one day, got a vaccine, and were then autistic after that, and somebody should at least listen to them.
Absolutely.
And not dismiss them and look at the real data, because I think it's important for public health to let's say that there is absolutely no correlation. You can slam dunk that. Well, that's a good thing to know, because I think
absolutely.
that would restore some confidence.
Yeah, one way or the other. Thank you so much. Thank you, Mr. Chairman.
Vice Chair Owen.
Very quickly, thank you again, gentlemen. Dr. Abraham, I'm not looking for an answer, but I just want to make sure that you're aware something Dr. Latipo has done in Florida on his recommendation about not recommending the COVID vaccines this winter. And I would ask that you review that, and I'm just making sure that you're aware of that.
I am aware, and I'll tell you straight up, Representative Owens, at this point, I'm not recommending the COVID vaccines for my patients either. Now, that goes back to that patient-doctor relationship. If that doctor and that patient want a COVID vaccine, that's fine. I just not recommend it for my patients specifically.
Thank you.
Representative Dickerson.
Thank you so much, Mr. Chair. Dr. Abraham, I want to ask, several people have emailed me, and I don't know the answer. I can't remember if we passed any legislation on this, or perhaps we need to. For those who have had blood transfusions, who have not been vaccinated and have had to have emergency transfusions, they're wanting to know if they get blood from someone who has been vaccinated, are they going to automatically possibly have problems in the future?
We don't know.
You don't know.
We don't know.
The verdict is, the jury is still out.
The jury is still out. This is still a very new disease in the history of diseases. Let's go back to the flu. It's been around for centuries. So we have data, but we continue to learn things on flus. This being only a 4-year problem, we honestly don't know what's in store, and that's very scary at this point, to not know that 10 years from now, you know, what, if anything, we may see.
Especially some of these young women who have had multiple miscarriages.
Yeah.
The jury is still out.
You know, we hope and pray that that's not going to be an issue. I'm skeptical that it's not going to be an issue, simply from what I've seen in these last 2 years on this vaccine injury issue. I hope I'm wrong.
Yes, sir.
We'll see.
Again, I want to thank you both. It's been amazing what we've heard for 2 days now, but I want to thank you for all that you're doing. And I want to thank you both for your honesty and for everything that you've enlightened us on so many levels. And thank you for your time for being here today as well.
Thank you.
All right, gentlemen. The board is clear, but I have a couple of follow-up questions, and I'm going to let you all off the hot seat.
All right.
real quickly, Dr. Abraham or Dr. Coleman, whoever wants to answer, at what point did you realize that you had a treatment, an early treatment that worked? At what point of the pandemic?
Early.
May of 2020?
Oh, before that? No, 2021? No, May of 2020. Before that.
So-
we were seeing active Delta patients in early 21, January. We know the virus was probably in country October, maybe even before that. But when the pandemic hit, when so many people started getting so sick, my responsibility to my patients was to do what I thought was medically best. So we started with those treatments very early in the pandemic and saw results.
And just for clarity, 2020 or 2021?
2020.
2020. Say springtime of 2020, you would
Before
realize,
that.
even before that?
Yes, absolutely.
So you're going back to 2019.
Well, that late December 2019 and then into January, of course, 2020 and then progressively forward from that.
So based on your experience with your patients, by late 2019, early 2020, you had discovered or had figured out an early treatment remedy for COVID-19.
In my opinion, definitely.
Thank you, sir. Dr. Coleman, anything to add?
No, I think I'll have to leave that one to the real doctors.
You're the eyeball guy, that's right.
I'm the eyeball guy.
And then one
I
final...
have very limited utility.
And then one final question. There's been talk about profit motive and money, and you hear it all the time. So just based on your experience, your opinion, remdesivir, what's the cost of remdesivir?
Early on, it was very expensive. I couldn't tell you the cost now.
Is it more expensive than, say, ivermectin or hydroxychloroquine?
I would say yes.
Significantly?
At one point, much more, yes.
Do you think that played into the choice of treatment?
I don't know. It's it raises my antennas, though.
Very well, as it does mine. Surgeon General, Dr. Abraham, thank you. Deputy, what's your title, Dr. Coleman?
I think it's Deputy Surgeon General.
Deputy Surgeon General,
Yes.
Dr. Coleman.
Thank you.
Again, I want to thank you all for coming here this morning. We greatly appreciate your testimony. We appreciate your candidness, your openness, and your willingness to be honest and speak your mind. And thank you for standing up for freedom.
Thank you.
Thank you.
All right, with that, we're going to move on. I'm going to try to help everyone out here in the audience. So we're going to bring up next, by request, the Louisiana State Board of Nursing. And on deck,